I'm Dr. John Cole. I have offices in Atlanta, Georgia, and New York City. I've been involved in the hair restoration surgery field since 1990. I became interested in hair restoration surgery because as a young physician, I was looking for a field where I could make a reputation for myself at an early age. I felt that was important. When I looked at hair restoration, it was a field that had not advanced in 30 years since its first published article in 1958. The results were horrendous. And then I began to talk to patients who had hair restoration. And I asked them, how do you like having your hair back? And they all told me the same thing. I love having hair. And then I asked them the next question, which was, is there anything you'd like to see different in your hair restoration? And every one of them said the same thing. I wish it looked more natural. Now, I can remember when I first started in the field, when you told other colleagues that you were in the hair transplant business, they would kind of look down on you. And I think the reason was the results were so bad. I can remember watching Jerry Seinfeld where he would, every season, make fun of somebody that had hair plugs. And, you know, it's true that young men in their teens or their early 20s will be ridiculed by their friends, by their colleagues, because of their hair loss. And some of them drop out of college for that reason. Some of them will not take a job where they can't wear a hat. They avoid places where they can't wear a hat, like going to church or a funeral or even a graduation, maybe even for their own child, a wedding. They avoid these things. They avoid mirrors. And, you know, even though hair loss is a completely normal, natural process that everyone, in my opinion, should be able to accept, there are a percentage of men, and obviously all women that have hair loss, who just feel insecure because of their hair loss. So that's how I got into the field, and I jumped into it with beaming enthusiasm to create something that looked natural. And so I looked at the way hair grew, and I said, maybe I can put it back the way it grows. And I bounced that off the chief editor of the current hair transplant text, and he told me it won't work. Well, being someone who doesn't take no for an answer, I jumped into it with both feet and never looked back. The results were better, they were natural, and I got coverage much faster. And that transition from the early 1990 to about 1995 completely changed the hair restoration surgery field. And I wasn't alone. There were 2 or 3 others that took this leap of faith in something new and changed the industry for good, for the better. The process was to improve the aesthetic appearance in what we call the recipient area, you know, where you were bald. That was the first step. Along the way, there was steps to improve the efficiency of harvesting from the donor area. But the third step was to eliminate the ugly scar in the back of the head. And that's where I began to develop the follicular unit extraction technique. I wasn't the first person to do it. I wasn't the person who called it follicular unit extraction. But I was the one that perfected the way to get those follicles out. Because when you're taking out individual follicular groupings, you have to know what to use, and you have to know how to use it. And so the instruments didn't exist. So one of the things I had to do in 2003 was develop a complete instrument line for this particular procedure. And now, Follicular unit extraction is over 80% of all hair transplant procedures. Hair loss it's a lifelong process. And hair loss is nothing more than accelerated aging. The hair follicles tend to age much quicker than other parts of the body. You know, you can have a young man with a 20-year-old or a 25-year-old face, but he has the hair loss pattern of a 50-year-old man. Now, those individuals who start losing their hair in their teens, early 20s, even into the early 30s, are going to have much more extreme degrees of hair loss. And so these individuals that have advanced patterns in their early 20s are not particularly good candidates for a hair restoration surgery procedure, because hair restoration surgery is nothing more than moving the trees from the backyard to the front yard. And so you're going to eventually run out of shade in the backyard if you keep taking trees out, right? So the concept of regenerative medicine is one where we focus on maintaining the trees in the front yard that you were born with, so that we don't have to eliminate the supply of trees in your backyard, and then helping you maintain that coverage for as long as possible. You know, people have a lifespan, and that lifespan is generally going to outstrip the lifespan of their hair follicle. So it's so important to not just, you know, improve the longevity of our patients and make them feel better as they get older, but also to keep aesthetically their hair looking full, because otherwise the alternative is you're eventually going to become bald and we're going to run out of hair. Regenerative medicine for hair follicles, essentially, you're going to attack at two levels, really. One is you're going to try to upregulate noggin production from the dermal papilla, and at the same time downregulate BMP, which will turn on the beta-catenin pathway and initiate a hair growth cycle. The other thing you have to do is reduce inflammation, because all hairs grow, rest, or shed, and then regrow. They're not like your fingernails that just keep growing. So they're cyclical. And they have a limited number of cycles, like all cells can divide only so many times. And every time they divide, the telomere is shorter. So the key is to prolong the duration of the growing cycle and to get the maximum lifespan out of every single hair, and stop that constant turnover, which accelerates. Instead of growing for 5 years, a hair follicle might grow for 2 or 3 months, and then you shed it and you start another cycle. So those hairs go away pretty quick. So how do we attack that? Well, we've got to upregulate the noggin beta-catenin pathway and reduce inflammation. Now, what's going to work? Well, I kind of liken the way we approach any regenerative medicine is what I do is a number of different protocols, one of which is nanofat, but I also make stromal vascular fraction, and I combine that with microfat and nanofat. I believe there is a place for microfat in hair restoration. You know, we have scars, and we have something called a scalp reduction, both of which can reduce the volume of the tissue. So sometimes adding volume is very important, but as Gordon Sasky pointed out, a combination of SVF plus microfat is going to give you a better hair regeneration plan than will microfat alone or microfat plus nanofat. So you want to stimulate the follicles. I think nanofat's a great addition to hair restoration surgery. I think that we have to put cells in there. I think that the secretome is probably the major influential aspect of any type of regenerative protocol when we're using cells. So many times I combine a high density PRP with adipose, and that adipose oftentimes will contain a version of nanofat, plus I like to add saline into my nanofat or even into my microfat before I create the nanofat, and that gives me a little cellular pellet in that saline. So it's sort of an add-on. I really haven't seen much discussion at this particular meeting regarding the way we're approaching new protocols, but these new protocols actually do produce higher cell counts. In hair restoration, we move a little bit slower than a lot of the fields, like orthopedics, plastic surgery. I know a lot of the plastic surgeons were writing textbooks in 2010 about stromal-enriched lipografts and whatnot. The hair restoration field, I was probably the first or second guy in the whole field to get into fat. The other being Jeff Epstein, and who's down in Miami. Really, really great guy. Now, I believe that we have to take what's currently available and we have to push the science a little more. And we got to get something extra out of it. For example, just with PRP, I know we have to hit high concentrations of platelets, and there's ways to do it. But you also, to treat a scalp, you need 8 to 10 cc's of volume. So to hit high platelet count numbers and enough volume, there are only a handful of kits that will allow you to do that. But I take it a step further. There is a traditional means of activating PRP, which is the use of calcium gluconate, or you could use recombinant thrombin, but most people use calcium chloride or calcium gluconate. I sonicate the platelets, and I have a protocol that's 30-minute sonication using this ultrasonic energy to cause a cavitation and burst the platelets. So when I prepare a PRP, it is going to be typically between 1 million and 1.5 million platelets per microliter, from a baseline platelet count of, let's say, 200, 220. And when I sonicate it, my platelet count will be about 7,000. So I burst almost all the platelets, and what that does is it produces about 5 times the concentration of the high molecular weight growth factors. So what I believe happens is platelets have 2 functions, really. One is to control bleeding by clumping, and the second is to initiate repair. And we don't really care about stopping the bleeding. We're interested in that other function platelets have, which is to initiate repair and rejuvenation of the tissue. So those clumps, I believe, act like a screen door, and it limits the ability of the high molecular weight proteins to get out. They're too big to get out. They're in the 24, 28 kilodalton range. But the low molecular weight growth factors like IGF, down around 7.8 kilodaltons, it's going to be an equal concentration regardless of whether you activate or whether you sonicate. So that's one thing I've done that's completely different than anybody else. In regard to adipose, I take what I'm taught. And the first device I saw on the market was the Tulip device. And the first harvest and preparation of microfat and nanofat for a facial rejuvenation procedure I saw with Angelo Trevisono when I was helping to set up a clinic in Rome, Italy. And he prepared it using the Tulip devices. So right away I jump into Tulip. And they come up with clever ideas on how we might improve the cell content. Now, I've done so far 2 comparative trials at major medical meetings where we compared multiple devices and multiple ways of preparing our cellular material, and then counting cells, followed when possible with flow cytometry to look at which means of preparing the tissue is going to give us the best cluster differential profile, and which is going to give us the higher cell count. Now, I think it's very important to have high cell counts because we do know that in regeneration of tissue, all tissues have stem cells. They just don't have enough to repair an injury. Like if you had a stroke, you don't have enough brain stem cells, but you can recruit them from the bone marrow. It's just we don't make as many. We don't have as many as we had when we were younger, when we don't really necessarily need them. So I think cell counts are important. The real issue is, even though Patricia came up with us knowing there are stem cells in adipose in 2001, we're yet to successfully modify these pluripotent cells into specific structures like hair follicles. So there's going to be a way. We're going to find a way. When and how we're going to do it, I'm not quite sure, but I can tell you just from going in the lab and looking at the influence of adipocyte-derived stromal tissue, cultured adipose stem cells, on hair follicles. They're very stimulatory. In fact, they're the most stimulatory of all media, including platelet lysate. They're very close in terms of proliferation of the dermal papilla. But normoxic cultured adipose stem cells are the most influential in terms of FGF7 production, which is a potent activator of the cell cycle, which, as I go back to, is very important in the hair follicle in terms of prolonging its lifespan. So fat's where it's at, and it's just sometimes a matter of getting patients from the concept of performing the procedure to doing the procedure and then repeating the procedure. So I think one of the most important things we have to look at today, and I know it's not necessarily ideal for Tulip, is we got to bank cells. Because not all people have good quality cells. And as we age, the quality of our cells deteriorates. We don't have that same great cell that we had when we were young. And we have all these influences from the environment that impact us epigenetically. And they have a negative influence on our stem cells. So if we consider that all fat is not equal, we have to find the best possible cells, and sometimes that means getting those cells out when you're in your 20s and 30s and preserving them into your 70s, 80s, and hopefully past 120. I was introduced to the Tulip products by Dr. Angelo Trevisono, who is a plastic surgeon in Rome, Italy. And he showed me how to use them. I didn't have to see it twice. The protocol is really quite simple. So they're a user-friendly means of processing adipose. In fact, it's probably the most user-friendly means of processing adipose of all the devices on the market. If you've ever had your grandmother cook a stew or made a dish and you can't find anybody else that can quite get it right, that's how complicated some of these protocols are that are being done with some manufacturers. And I'm not sure that they're reproducible. So what you get with Tulip is a consistent product. You're going to be able to learn the process and the procedure rapidly, and you're going to produce a great microfat and nanofat. So it's a wonderful product.